Good evening, everyone. The Foundation for Reproductive Care Incorporated and the Division of Gynecologic Oncology, Department of Obstetrics and Gynecology, College of Medicine of the Philippine General Hospital, University of the Philippines, Manila, welcome you to Dare to Dream, reimagining management of advanced ovarian cancer across lines of therapy with first-in-class PARP inhibitor Olaparib Lynparza. Ladies and gentlemen, we will start in 5 minutes. This session is supported by AstraZeneca. The content is intended for healthcare professionals for medical education purposes only. Experts' opinions of the participating speakers are based on their experience to date. AstraZeneca does not engage in the promotion of unregistered products or unapproved indications. Please consult local prescribing information for registrations and product license details. Good evening, everyone. The Foundation for Reproductive Care Incorporated and the Division of Gynecologic Oncology, Department of Obstetrics and Gynecology, College of Medicine in the Philippine General Hospital, University of the Philippines, Manila, welcome you to Dare to Dream, reimagining management of advanced ovarian cancer across lines of therapy in first-in-class PARP inhibitor Olaparib Lynparza. We will begin the program with an invocation to be followed by the Philippine National Anthem.
For a brief moment, let us pause in our daily preoccupation and feel the strong and reassuring presence of our Lord. Heavenly Father, look with kindness upon all of us who are gathered here. Fill our minds with wisdom and fill our hearts with love and joy as we begin this day. As we become entangled in the web of our professional and personal interactions, enable us to feel the warmth of one another's friendship. Look with kindness upon our leaders. Strengthen their wills to enable them to infuse excellence and relevance in all our undertakings. Look with kindness upon the pillars of our society. May their legacy of hard work and productivity continue to inspire our faculty and trainees. Look with kindness upon the organizers of this webinar. May they be amply rewarded for a job well done. Look with kindness upon our trainees, the residents in the specialty, and the fellows in the subspecialty. May they continue to strive for excellence as they find joy in camaraderie and mutual support. Look with kindness upon the attendees of this webinar. May they learn from the session so they can better care for their patients. Look with kindness upon our friends in the pharmaceutical industry. May they continue to be our eager partners in these kinds of endeavor. Look with kindness upon the women afflicted with cancer, the women who have recovered from cancer, and the women who are at risk of developing cancer. May our concern for them be as deep, pure, and genuine as your concern for all of us. And at the end of the day, allow us to raise our hands to you in praise and in thanksgiving for allowing all these things to happen. Amen.
To formally open tonight's activity, we would like to welcome Dr. Efren J. Domingo, Chair of the Gynecology at the University of the Philippines, Philippine General Hospital.
Good evening to all our attendees. In behalf of the UP Manila Chancellor Padilla, UPCM Dean Chong, PGH Director Legaspi, I, Dr. Efren J. Domingo, Chair of the Department of Obstetrics and Gynecology, welcome you to the webcast of the Division of Gynecologic Oncology entitled Reimagining Management of Advanced Ovarian Cancer Across Lines of Therapy with First-in-Class PARP Inhibitor, Olaparib. Our speakers tonight are two of the best experts in ovarian cancer in the country. Both are Professor 12 of the UP College of Medicine, and both have a wide range of experience in the care and handling of the most difficult of ovarian cancer cases. Dr. Malia Lilibet Siasu and Dr. Jericho Tadeus Luna. At this time, when the remaining hope for the advanced and recurrent and persistent ovarian cancers revolve around PARP inhibition, Olaparib is providing the needed prolongation of survival. Dr. Renee Sikam will be the most qualified moderator to handle the webcast up to the question and answer portion. We thank our division consultants for ably supporting the webcast, as well as all our division fellows in training. Congratulations for providing our gyne-oncologists the best opportunity of learning and be able to impart new treatment options to our ovarian cancer cases. Thank you and good evening. Back to you, Dr. Sikam.
Thank you, Dr. Efren Domingo. We would like to introduce our moderator for tonight, Dr. Renee Vines Sikam. Dr. Sikam is a clinical associate professor and a research coordinator at the Division of Gynecologic Oncology, University of the Philippines, Philippine General Hospital. Dr. Sikam, please take the virtual floor.
Good evening. Hello, everyone. So welcome to our division's webinar. So before we begin, let me read our house rules. So kindly ensure your microphone is muted while the lectures are ongoing. Raise your hand, click is on the menu when you have any questions, and wait for me, the moderator, to acknowledge you. You may input your questions in the Q&A button. Questions will be entertained at the end of the panel discussion, and this webinar is being recorded. So let's just go through our agenda. So this is our agenda. We have the first speaker, and then lecture in between, and another lecture, then a panel discussion and Q&A. And this will be ended by closing remarks. So let me introduce to you our esteemed speakers. So as the title implies, first in its class. So right now we have the speakers are first in their class. So let me introduce the first speaker. Maria Lilibeth L. Shasu is Professor 11 of Gynecologic Oncology in UP-PGH. She is the past president of the SGOP, PSCPC, and the past chair of PBOG. She is an Honoria Acosta Season awardee and Merit for Research in POGS 2016, and Ramon Lopez Award for Merit for Community Service, also given by POGS in 2018. She received the Most Outstanding Researcher Award from the PSO in 2019. Our next speaker is Dr. Suruchi Agarwal. She's a senior scientist in oncology. She has a Master of Science in Human Genomics and a doctorate degree in Human Genomics. She has 5 years experience in oncogenomics with understanding of cancer biology and associated biomarkers. She has an expertise in interpretation and analysis of NGS-based cancer genomic tests, both somatic and germline, with over 1,000 cases addressed. Matured with diagnostic, prognostic, and therapeutic implications of genetic testing in cancer. So she worked on development, validation, and optimization of targeted cancer-specific or pan-cancer NGS panels for tissue-based as well as liquid biopsy testing. And our last speaker is Dr. Jericho Thaddeus Luna. He is Professor of Gynecologic Oncology and he is our Division Chief. So let's start with our first speaker. To speak on Olaparib landmark trials in ovarian cancer, let us welcome Maria Lilibeth L. Shasu. Dr. Shasu.
Good day. I am Dr. Maria Lilibet Siasu of the Division of Gynecologic Oncology of the UP College of Medicine, Philippine General Hospital. I would like to thank the division for the opportunity of giving this lecture. This is an industry-sponsored lecture. Dare to Dream, Olaparib Landmark Trials in Ovarian Cancer. This is the outline of my presentation. Ovarian cancer is the deadliest of all gynecologic cancers. A woman's lifetime risk of developing ovarian cancer is 2.7%. Two-thirds of the ovarian cancer mortality is attributed to the high-grade serous carcinomas. An estimated 18% of cases are associated with germline mutations, most of which are attributable to BRCA1 or BRCA2 mutations. 15% of all epithelial ovarian cancers are homologous recombinant deficient. 50% of high-grade serous ovarian cancers may be deficient in homologous recombination. High-grade serous carcinoma is the most common histology associated with germline BRCA1, BRCA2 mutations. Other histologies except mucinous may have germline mutations. Hence, testing of all women with epithelial ovarian cancer is recommended by all of these organizations: the ESMO, NCCN, ASCO, and SGO. The standard therapy for ovarian cancer consists of cytoreductive surgery and a platinum-based chemotherapy with or without concurrent maintenance bevacizumab, which is a vascular endothelial factor A inhibitor. The median PFS of advanced ovarian cancer treated with surgery and a platinum combination therapy is 10 to 18 months, and 70% will relapse within 3 years. The median overall survival for patients with a platinum-sensitive recurrent ovarian cancer is 2.5 to 3 years. Most patients typically receive a median of 4 lines of chemotherapy after progression. PFS for these patients ranges from 8 to 13 months from the start of the second-line chemotherapy. Up until now, recurrent ovarian cancer remains incurable. Among patients who respond to further platinum-based chemotherapy, the median PFS from the end of treatment is 5 to 6 months, and most patients are offered with the next line of palliative chemotherapy. Cumulative toxicities of chemotherapy and the emergence of drug resistance limits delivery, leading to a decreased benefit of further treatment. The effect of salvage chemotherapy given for tumor progression decreases with each subsequent line of treatment. There is a significant need for a better frontline treatment as well as an effective and well-tolerated long-term maintenance treatment option for patients with recurrent ovarian cancer to maintain quality of life and delay subsequent need for chemotherapy after response. With the advent of newer drugs like PARP inhibitors, it is best to have an earlier knowledge of genetic mutations and biomarkers so as to guide us in our choices of treatment. Let us briefly review PARP, poly-ADP ribose polymerase, BRCA, and homologous recombination. Homologous recombination is a high-fidelity repair process for double-strand DNA breaks, while your BRCA1 and 2 are key proteins required for the formation of the repair complex at the site of DNA damage. Germlines or somatic mutations in BRCA1 and 2 genes result in dysfunction of their protein products, which create genetic instability and thus a predilection of affected cells for malignant transformation. Other genetic aberrations can occur in the homologous recombination pathway, including mutations in other homologous recombination genes and epigenetic changes, such as inactivation of BRCA1 or 2 or methylation of promoters. PARP is an enzyme that plays an essential part in the repair of single-strand DNA breaks through the base excretion pathway and keeps the low-fidelity non-homologous and joining DNA machinery in check. In normal cells with intact homologous recombination pathway, PARP inhibition is inconsequential given the accurate repair of the double-stranded breaks. In cells with BRCA1 or 2 mutation or other abnormalities in homologous recombination, PARP inhibition results in a process termed as synthetic lethality, whereby two mechanisms of DNA repair are functionally terminated, leading to a reliance on non-homologous end joining and subsequently cell death. PARP inhibitors exploits the underlying defective process in cancer cells. Olaparib is a PARP inhibitor that induces synthetic lethality in BRCA1 and 2 tumor cells. Olaparib is theorized to work in two potential mechanisms. First, by allowing the persistence of spontaneously occurring single-strand breaks due to a loss of enzymatic function. Second, by preventing the release of PARP from DNA, also known as PARP trapping. Both mechanisms lead to a persistent of single-strand breaks, collapsed replication fork, and resultant double-strand breaks. Olaparib was approved by the US FDA for the treatment of ovarian, pancreatic, breast, and prostate cancers based on the underlying mechanisms of malignancy. For ovarian cancer, Olaparib has been approved by the FDA for the following indications. 1. As maintenance treatment in germline or somatic BRCA mutated epithelial ovarian cancer with complete or partial response to the first-line platinum-based chemotherapy. Second, as a maintenance treatment for recurrent epithelial ovarian cancer with complete or partial response to platinum-based chemotherapy. And third, as treatment of germline BRCA mutated advanced ovarian cancer with 3 or more prior lines of chemotherapy. Olaparib was initially approved by the US FDA in 2014 for women with recurrent ovarian cancers who had germline BRCA 1 or 2 mutation and had received 3 or more prior lines of chemotherapy. This was based on Study 42, which demonstrated an objective response rate of 30% with Olaparib monotherapy in a heavily pre-treated population. Soon after, the European Medicine Agency approved Olaparib as maintenance monotherapy for patients with platinum-sensitive relapsed BRCA 1 or 2 mutated high-grade serous ovarian cancers, fallopian tube, and primary peritoneal cancers based on Study 19. In 2017, the US FDA broadened its approval on Olaparib to include maintenance monotherapy for patients with platinum-sensitive recurrent ovarian cancer, regardless of the BRCA mutation status. The European Medicine Agency followed shortly with an approval that matched these indications in 2018. Most recently, it was approved for frontline maintenance therapy in BRCA mutated advanced ovarian cancer. This was after a phase 3 trial which showed significant improvement in PFS in this subgroup when compared to placebo. The hazard ratio of 0.30 with a 95% confidence interval of 0.23 to 0.41. Let us look at the Olaparib landmark trials in ovarian cancers. These trials formed the basis for approval of Olaparib by the Philippine FDA. Study 19. Study 19 was a randomized double-blind placebo-controlled phase 2 study evaluating maintenance treatment with Olaparib among patients with platinum-sensitive relapse high-grade serous ovarian cancers who has received 2 or more platinum-based regimens with partial or complete response to their most recent platinum-based regimen. Olaparib was given at 400 milligrams twice daily versus placebo treatment, and the primary endpoint was measuring PFS according to the response evaluation criteria in solid tumor guidelines or the RECIST guidelines. 265 patients were enrolled. 136 were in the Olaparib group and 129 in the placebo group. The PFS was 8.4 months versus 4.8 months from randomization on completion of chemotherapy for Olaparib versus placebo, respectively. The hazard ratio for progression or death was 0.35 and a 95% confidence interval of 0.25 to 0.49 with a significant p-value. Subgroup analysis of PFS showed that, regardless of subgroup, patients in the Olaparib group had a lower risk of progression. The adverse events reported in the Olaparib group were more common than in the placebo group by more than 10% of patients. Majority of the adverse events, however, were grade 1 to 2. In addition, Olaparib demonstrated efficacy in non-BRCA mutated patients, reducing their risk of progression by 46%. At the final data cutoff, an overall survival advantage was observed in the Olaparib group as shown in this Kaplan-Meier curve. Olaparib as maintenance therapy significantly improved PFS among patients with platinum-sensitive relapse high-grade serous ovarian cancers, even when given for a longer period of time. The SOLO2 trial was a randomized phase 3 study that enrolled 295 patients with germline BRCA1 or 2 mutations and platinum-sensitive recurrent high-grade serous ovarian cancers and high-grade endometrial cancers, including primary peritoneal or fallopian tube cancers, having relapsed after 2 or more prior chemotherapy. 196 were in the Olaparib group and 99 in the placebo group. Patients received 300 milligram tablet twice daily in the Olaparib group. The results of this study showed that the median progression-free survival with maintenance Olaparib tablet versus placebo was 19.1 versus 5.5 months with a hazard ratio of 0.30 with a significant p-value. This means that the risk of progression or death during the study was reduced by 70% for patients taking Olaparib. These results confirm the findings of Study 19 and provided further evidence for Olaparib in platinum-sensitive high-grade serous relapse ovarian cancer. The adjusted mean change from baseline over the first 12 months in trial outcome index showed that Olaparib maintenance therapy did not have a significant detrimental effect on the health-related quality of life compared with the placebo. There were clinically meaningful patient-centered benefits, despite the toxicity experienced by patients receiving Olaparib versus placebo. The endpoints supported the improvement in PFS, which was the primary endpoint in SOLO-2. The final analysis of overall survival results from SOLO-2 showed that the median overall survival improved by 12.9 months with maintenance Olaparib over placebo, even when 38% of placebo patients and 10% of Olaparib patients received PARP inhibitor therapy. Over half of patients were progression-free in the Olaparib arm at 18 months, compared to only 16% in the placebo arm. Conclusions derived from Study 19 trial showed that Olaparib significantly prolonged PFS by 65% versus placebo in the intent-to-treat population, with median PFS of 8.4 months versus 4.8 months. And the benefit was seen in both BRCA mutated and non-BRCA mutated populations. Study 19 had the longest follow-up of any PARP inhibitor, with approximately 20% of patients remaining in the treatment after 3 years, and over 10% of patients remaining on treatment after 6 years. Adverse events in Study 19 were mostly mild or moderate and did not lead to treatment discontinuation. Maintenance Olaparib also had no detrimental effect on health-related quality of life compared with placebo. SOLO-2 demonstrated a large, clinically meaningful, significant PFS improvement in BRCA mutated platinum-sensitive recurrent ovarian cancer. In the SOLO-2 study, the PFS was significantly prolonged by 70% in the Olaparib group versus placebo among patients with BRCA mutation. 43% of Olaparib-treated patients remained progression-free at 2 years versus 15% in the placebo arm. There was an improvement on median overall survival by 13 months, an impactful benefit for women in this subgroup. The SOLO-1 study was a randomized double-blind phase 3 trial that enrolled 391 patients with newly diagnosed advanced ovarian cancer with germline or somatic BRCA mutations who had a clinical complete or partial response to a platinum-based chemotherapy. Treatment intervention was continued until disease progression. Patients with no evidence of disease at 2 years stopped receiving the treatment intervention, while patients with a partial response at 2 years were allowed to continue treatment in a blinded manner. The primary endpoint was an investigator-assessed PFS. 60% of patients on Olaparib remained progression-free at 3 years versus 27% for placebo. After a median follow-up of 41 months, the risk of disease progression or death was 70% lower with Olaparib than with placebo. And the PFS benefit of maintenance Olaparib was sustained beyond the end of treatment as shown in this slide. Over a quarter of patients with evidence of disease achieved a complete response to Olaparib. The adverse events were mostly mild to moderate in the Olaparib arm. Grade 3 or more adverse events occurred in 39% of patients in the Olaparib arm versus 18% in the placebo arm. Conclusions derived from the SOLO-1 trial are as follows. Olaparib maintenance therapy after platinum-based therapy provided a substantial unprecedented benefit in PFS among women with newly diagnosed ovarian cancer and BRCA1 or 2 mutation with a 70% lower risk of disease progression or death. The benefit derived from 2 years of maintenance Olaparib was sustained beyond the end of treatment. More than 50% or approximately 50% of women who received maintenance Olaparib for 2 years remained progression-free 5 years later. Olaparib was generally well tolerated with a safety profile consistent with that observed in relapse disease setting. Maintenance Olaparib should be considered standard treatment following platinum-based chemotherapy for women with newly diagnosed advanced ovarian cancer with a BRCA mutation. The practical implementation and key takeaways from these studies are: Olaparib is approved across lines of therapy for both BRCA mutated and non-BRCA mutated advanced ovarian cancer. As maintenance treatment for advanced high-grade epithelial ovarian, fallopian tube, or primary peritoneal cancers who are in response to first-line platinum-based chemotherapy with bevacizumab. As maintenance monotherapy treatment for newly diagnosed advanced BRCA mutated high-grade epithelial ovarian, fallopian tube, or primary peritoneal cancers who are in response to first-line platinum-based chemotherapy. As maintenance monotherapy treatment for patients with platinum-sensitive relapse high-grade epithelial ovarian, fallopian tube, or primary peritoneal cancers who are in response to platinum-based chemotherapy. And fourth, as monotherapy treatment of adult patients with deleterious or suspected deleterious germline BRCA mutated advanced ovarian cancers who have been treated with 3 or more prior lines of chemotherapy. In the Paula 1 study, it showed a 41% reduction in risk of progression or death. In the Solo 1 study, a 70% reduction in risk of progression or death. In the Study 19 trial, a 65% reduction in risk of progression or death. And in the Solo 2 study trial, a 70% reduction in the risk of progression or death. And in the Solo 3 trial, a 2.5 times improvement in the overall response rate for complete response and partial response. Olaparib or Lynparza is supplied in 100 milligrams and 150 milligram coated tablets. For more prescribing information, you can scan the QR code. Olaparib or Lynparza, indications for ovarian, pancreatic, breast, and prostate cancers are shown in this slide. The advent of PARP inhibitors is an unprecedented advancement in the treatment of ovarian cancer. With the Solo 1 study, Olaparib has the potential to redefine the goals of first-line treatment in patients with BRCA-mutated tumors, bringing long-term remission and hope for a potential cure. These trials may be the answer to the dream of a brighter future for our patients with advanced ovarian cancer. I would like to thank Dr. Ria Rada Garcia, Glenn, and Cheska Laconico in the preparation of this lecture. Thank you.
Okay. So for our next speaker, we'll listen to Dr. Suruchi Agar, Agarwal. She will talk about BRCA and HRD testing. Dr. Suruchi.
Thank you. Thank you. Good evening, everyone. I'll be sharing my screen. I hope my screen is visible to everyone. Okay. So I am Dr. Suruchi, working as a senior scientist oncology in MedGenome Labs, Bangalore, India. And today it's an honor for me to speak here in this symposium. And I would like to extend my thanks to Dr. Maria for wonderfully highlighting the use of Olaparib across lines of therapy for both BRCA mutated and non-BRCA mutated ovarian cancers. So today I'll be mainly talking about as to why genetic testing is important in ovarian cancer. What are the different biomarkers involved in the development of ovarian cancer progression and use of targeted therapy and prediction of treatment outcomes. So I'll be also highlighting standard medical guidelines as also highlighted by Dr. Maria for genetic testing in ovarian cancer. Then I'll touch upon germline versus somatic versus HRD testing. What are the sample types, challenges, and workflows? and what are the major factors to look upon in the laboratory where genetic testing is done and what we offer at MedGenome. And lastly, how to interpret genetic testing results. So to begin with, landscape of mutations in ovarian cancer. As you can see, up to 20% of ovarian cancer patients are BRCA mutated, out of which 12 to 13% are of germline origin, and rest are present in tumor only or somatic. There are other genes involved in homologous recombination repair pathways, mutations in which account for about 10% of ovarian cancer cases. Besides, some epigenetic changes and other identified causes are also present in about 20% of ovarian cancer together. All these events leads to a phenomenon called HRD, explained nicely by Dr. Maria, which is an inability to repair DNA damage efficiently by the cells, and it results in genomic instability. When these genomic aberrations are accumulated in the cells, it transforms into cancer. And PARP inhibitors can lead to cell death in such cells. Therefore, it has been approved as targeted therapy. So HRD can be tested directly using NGS-based HRD assays. So in continuation with this, why we have to go beyond BRCA1 and BRCA2 testing? So genetic testing of germline BRCA will identify only 15% of women with ovarian cancer, high-grade ovarian cancer. Further, tumor testing will add upon, say, 8 to 10% of women. If we go beyond BRCA1 and BRCA2 to test other HRR genes, which another 7 to 8% of ovarian cancer patients can be identified for PARPI benefit. And if we test BRCA1, BRCA2, and HRD together, so PARPI benefit can be extended to up to 50% of women with high-grade ovarian cancer. So why genetic testing is important in ovarian cancer patients? We can identify BRCA1 and BRCA2 mutations and other HRR gene mutations and HRD status by genetic testing. And this information helps to make informed treatment decisions. BRCA mutations or HRD sensitizes cells to platinum-based therapies, which are first-line treatment and in newly diagnosed patients. And PARPI can benefit as first-line maintenance therapy and is FDA approved. So in ovarian cancer survivors for beyond 5 years or 10 years, retesting will benefit as advancements in genetic testing allows current tests to identify mutations that could have been previously missed by older tests. So retesting ovarian cancer survivors is also beneficial. Lastly, genetic testing can benefit at-risk family members. It improves early detection and better management of disease. And some male members should also be tested as they have risk of developing other cancers such as prostate, pancreatic, breast cancers if they carry BRCA1, BRCA2 mutations. So now what guidelines recommend? In a nutshell, all women with ovarian cancer, fallopian tube, in a nutshell, all women with ovarian cancer, fallopian tube cancers, and primary peritoneal cancers should be tested regardless of age and family history at the time of diagnosis. And as you can see here in the revised footnote of NCCN guidelines, it says that tumor tissue testing is also recommended, plus HRD testing is also recommended. And there are other biomarkers like microsatellite instability is also recommended by NCCN. Similarly, ESMO, ASCO, and SGO guidelines, they also highlight the same recommendation. Patients with high-grade tumors should be tested for germline BRCA mutation, and consideration should be given to testing tumors for somatic BRCA mutation. Similarly, ASCO says all women diagnosed with epithelial ovarian cancer should have germline genetic testing for BRCA1 and BRCA2 and other ovarian cancer susceptibility genes such as HRR genes. And in women who do not carry germline BRCA1, BRCA2 variant, somatic tumor testing should be performed. And women with epithelial ovarian cancer should be tested at the time of diagnosis itself. SGO guidelines again highlights the same point. BRCA testing for all patients with epithelial, ovarian, tubal, and peritoneal cancers, even in the absence of family history. So, regardless of age or family history, all women with ovarian cancers should be tested at the time of diagnosis. So, there are ESMO guidelines for HRD testing. Here, I just want to highlight that in newly diagnosed setting, it is reasonable to use a validated scar-based HRD test. Why HRD test is important in newly diagnosed setting? To establish the magnitude of benefit conferred by PARP inhibitors where BRCA wild type ovarian cancer is present, and where BRCA wild type patients where the PARP therapy will not be useful. So, to identify both these subgroups and to understand the lines of therapy for these subgroups, HRD testing is recommended. So now coming on to what are germline and somatic mutations. So this cartoon represents that germline mutations are present in gametes. So it is presented, it is present in all the cells of the body, whereas somatic, and these are inherited, germline mutations are inherited, whereas somatic mutations are acquired mutations during the lifetime, and it is only present in the affected cells. So germline mutations, since they are present in all the cells of the body, so they can be detected by a tumor test or a blood test. Whereas tumor mutations or somatic mutations, they are only present in the tumor or the site of the cancer, so they can be only detected by tumor testing. But tumor testing, as mentioned, can detect both germline and somatic mutations. So ideal testing workflow should be that if ovarian cancer patient is newly diagnosed or treated with platinum-based therapy, first-line BRCA testing should be done on tumor tissue, as it will pick both germline and somatic mutations. But point here to notice that it will not distinguish. So if somatic testing comes out to be positive, so it should be proceeded with germline testing for risk assessment in family members, and also it will be useful for asymptomatic family members if the BRCA mutation is present, so risk assessment can be done. And for germline testing, genetic counseling is required. Third, if somatic testing is negative, HRD test can be proceeded with, which detects genomic instability, and it is recommended in affected treated patients to know PARP inhibitor or PARP inhibitor plus bevacizumab benefit. And it is usually followed, as mentioned, it is usually followed by negative somatic test results, but also recommended in newly diagnosed patients. So, beginning with tumor test rather than a germline test has advantages. That tumor test in itself is conclusive if individual harbors BRCA mutation. Negative germline test will be inconclusive, and there is no need of 2 rounds of BRCA testing. Germline followed by tumor. We can test germline and tumor mutations by tumor testing itself. And one major point to note here is that going by only family history will miss major chunk of BRCA or HRD positive ovarian cancer cases, as 47% of women with BRCA mutated ovarian cancer does not have a family history. So therapeutic implications of HRD, of genetic testing. So there are 3 relevant subgroups for which the tailored therapy is available: germline or somatic BRCA mutated, HRD positive, and HRD negative. Olaparib by AstraZeneca is indicated in various settings, as mentioned here, in various settings of high-grade ovarian cancer. And like for germline BRCA mutated, treated with greater than 3 prior regimens, Olaparib is recommended as first-line maintenance therapy. Germline or tumor BRCA mutated frontline maintenance in combination with bevacizumab in HRD cancers, and recurrent disease with response to platinum therapy regardless of BRCA status. So coming on to sample type and workflow for germline testing, somatic testing, and HRD testing. For germline testing, peripheral blood in EDTA, about 4 ml is required, or it can be done on buccal swabs also. The test is done through next generation sequencing, and the sequencing is done up to 80 to 100x depth, and it reports single nucleotide variations, short indels, and copy number variations. Variants are reported as pathogenic, likely pathogenic in almost 30% of cases, and VUS in 5% of cases. The assay is validated, sensitivity, specificity, and reproducibility up to 100% has been seen in validation. For somatic testing, sample type is FFP tissue blocks, and minimum of 10% of tumor content or neoplastic cell content is required in the tissue block, which is assessed by a certified pathologist. And histopathology report needs to be attached with the FFP tissue block. And the DNA extracted from FFP tissue block should be almost 100 to 200 nanogram of unfragmented DNA. So the quality checks for DNA is done before proceeding for NGS testing. Again, for next generation sequencing, here the sequencing is done at 250x depth, and we report SNVs and short indels. 100% coding region are covered, including 10 base pair padding into introns to detect splice variants. And variant allele burden or mutation load detection is done up to 5%. So limit of detection of assay is 5% of variant allele burden. HRD testing is also done through NGS, and sample type is similar to somatic testing. However, the tumor content and DNA yield is little critical in HRD testing. We require minimum of 20 to 30% of tumor content for results to be QC passed. And HRD testing determines genomic instability by measuring genomic scar score, and reports usually as HRD positive and negative status based on GS score. And it is also validated assay performed using CEIVD approved kit. Excuse me. So one of the major factors in the success of tumor testing is FFP tissue quality factors, which depends on various factors like histopathological factors. Histopathological factors like sometimes the tumor is derived from a metastatic site, and it may have a necrotic tissue. So necrotic tissue is usually not very good. The DNA is fragmented. Poor fixation, burning effect, crushing artifacts during paraffin embedding are also major factors which affect the quality of DNA. Then the age of the block should be less than 3 years. The older blocks, they tend to have fragmented DNA. Then at the time of tissue processing, the percentage of formaldehyde used, then time lag between tissue removal and fixation, what was the fixation time used, were there any contaminants or decalcification in the process. These all factors, they play a wide role determining the quality of FFP tissue block, and further downstream processes are dependent on that. So sometimes the quality of DNA is not so good, so we don't get required coverage and depth for the genes when we go ahead with NGS. So QC failures, almost 10 to 15% of QC failures are noted on FFP tissue testing. So next, what should we look in the lab where we want to do the genetic testing, whether it is accredited, whether it participates in proficiency testing, standard proficiency, global proficiency testing in EQUAS programs. Technology, usually NGS is recommended. Sanger sequencing is not advisable for screening purposes. Whether the lab has expertise in bioinformatics analysis, and whether the assays are validated, stringently validated, based on these factors: sensitivity of the assay, specificity of the assay, what is the limit of detection of assay, whether cross-platform validation has been done, whether bioinformatics analytical pipeline validation has been done. So these all factors are important when we go for a genetic testing. So coming on to MedGenome's test portfolio, we offer both somatic and germline testing for BRCA1 and BRCA2 genes, as well as for HRR genes. We do large deletion duplication analysis by MLPA for BRCA1 and BRCA2 genes. We have recently started with HRD track assay, which determines genomic scar score and gives HRD positive and negative status. And we also do reflex test where if BRCA1, BRCA2 comes out to be negative on tumor tissue, followed by HRD test. And we have recently started off with HRR gene mutations testing on cfDNA samples to measure liquid biopsy in prostate cancer, mainly for prostate cancer samples, because the progression of prostate cancer samples is difficult to monitor on tissue, and recurrence and treatment response can be monitored by cfDNA testing. And prostate tissue is difficult to obtain also. Besides that, we have pan-cancer comprehensive hereditary cancer panel, which determines SNVs, indels, CNVs in BRCA1, BRCA2, HRR genes, plus other cancer-related genes. And similarly, comprehensive tumor panel, plus TMB, tumor mutation burden, and microsatellite instability markers on tumor tissue. Our tests are well validated and CAP accredited. We score 100% on CAP accreditation programs that happens twice a year. And we have tested around 8,000 breast cancer, ovarian cancer clinical samples so far. Coming on to interpretation and classification of variants. So for interpretation and classification of germline variants, ACMG guidelines are followed. ACMG guidelines classifies the variants into pathogenic, likely pathogenic, variants of unknown significance, and non-pathogenic, likely benign and benign. So pathogenic variants are usually clinically actionable, whereas uncertain significant variants and benign variants are not actionable. We do not report likely benign or benign variants. We report pathogenic, likely pathogenic, and variant of unknown significance. For a variant to classify as pathogenic or likely pathogenic, if the variant is a loss of function variant, known loss of function variant is not present in population databases, commonly present in population databases, that is, it has low minor allele frequency. And if it is reported in affected individuals and in clinical databases, if it is not a loss of function variant by type, there are functional studies which shows that the variant causes a loss of function of protein, and it is not present in healthy individuals. It segregates well in affected individuals. So these all criterias, they classify the variants as pathogenic or likely pathogenic category. Classification of somatic variants is done using AMP guidelines. AMP guidelines classify the variants into tiers. Tier 1, variant of strong clinical significance. Tier 2, variant of potential clinical significance. Tier 3, variants of unknown clinical significance. Tier 4, benign or likely benign variants. So here also further they are classified into levels of evidence. So if FDA-approved therapy or the marker is included in the professional guidelines for the particular tumor type that we are testing, it is classified as Tier 1A. If there is no FDA-approved therapy, but the biomarker is prognostically and diagnostically backed by well-powered studies with consensus from experts in the field and is included in the guidelines, it is classified as Tier 1B. If there are FDA-approved therapies for the biomarker in any other tumor types that is not being currently tested, then it is classified as Tier 2C. And if the biomarker is in some preclinical trials or few case reports are there, then it is classified as Tier 2D. And Tier 3, where the clinical significance is unknown, it is not observed at a significant allele frequency. We do not know what is the clinical significance of the variant, but variant is not even classifiable as a benign. So in those cases, variant of unknown clinical significance and benign or likely benign variants not causative of the disease and does not have any clinical significance. So here I would like to highlight how to interpret and classify VUS. Should VUS results be disclosed to the patients? Should a VUS result inform clinical management? What happens when a variant is reclassified? What follow-up studies should be done? And how should the patients be counseled? So, on these questions, ACMG guideline states that a VUS should not be used in clinical decision making, but efforts to resolve the classification of the variants as pathogenic or benign should be undertaken. While this effort to classify the variants is underway, additional monitoring of the patient for the disorder in question may be prudent. So, what does this mean? That VUS cannot be used for clinical decision making, but it can be classified as pathogenic or benign based on available evidences or the evidences that will come up. So it should be classified on case to case basis, looking at the patient's history, family history, how it is segregating in the family, and efforts should be made on one-to-one basis to reclassify the VUS variants and to identify whether it is a causative or it has some clinical significance or not. I would like to explain these points by taking an example. So there are two patients which are present in two different countries, and there is a family history of early onset of breast cancer. The mutation was detected, missense mutation in BRCA1 gene, and was reported as VUS. So these two unrelated patients, they had common phenotypes, same rate variant, provide insufficient evidence of pathogenicity, therefore classified as VUS. So 3 years later, and constant cross-country collaboration and segregation analysis in both the families of these both patients uh, later on led to the reclassification of this VUS variant to clinically significant variant. So, depositing phenotypes, collaboration, active collaborations, and depositing phenotypes and genotypes in freely accessible databases, it helps reclassification of variants, and the geneticists and genetic counselors should be actively looking at upcoming evidences for the VUS variants, which will actually aid in the management of the patients and family members with VUS BRCA mutations. Another recent article in Forbes, that tennis star Chris Evert teaches us that genetic testing is a lifetime match. So, Chris Evert is recently diagnosed with early stage ovarian cancer, and her younger sister succumbed to ovarian cancer at 62 years of age. She was actually tested for genetic variants and was detected with VUS in BRCA1 gene, and no action was taken for these VUS BRCA1 variant. Sorry. Uh, VUS was reclassified as pathogenic 4 years after her diagnosis and approximately 20 months after her death. So now, Sister Chris Everts was offered genetic testing and found that she had same pathogenic genetic variant, and she chose to have her uterus and ovaries removed. But when her tissue was sent to pathology, they found that in fact Chris already had ovarian cancer. But the tumor was at stage C, 1C, and she was having a very favorable prognosis. So the question is that our genetic testing and variant classification works on just testing and forgetting type of a system. So we should rethink the genetic testing process. The field of genomics is changing every day, and we need to stop thinking genetic testing as one and done and realize that patient, their families, and their clinicians need lifetime access to digital genetic information that is updated over time, and testing options and medical management recommendations are evolved. So, this is just a summary of testing in ovarian cancer. Why should we test? To identify the informed treatment decisions. Who and when to test: newly diagnosed advanced ovarian cancer patients, and we should test at diagnosis. What to test: BRCA mutations and genomic instability testing in tumor tissue should be done. Determination of germline BRCA status is appropriate to assess patient and familial risk. How to test: tumor tissue archival or newly obtained FFP plots. And key takeaway is NGS is the method of choice of identifying genetic variants in BRCA1, BRCA2, HRR genes, and HRD test, and MLPA for large deletions and duplications in BRCA1 and BRCA2 genes. Somatic testing will pick up both germline and somatic variants, hence is recommended to benefit most number of patients from targeted therapy. Laboratory should follow recommended guidelines for NGS testing and reporting. FFP block preparation and quality is very crucial for successful NGS assay. HRD and BRCA testing is crucial for personalizing first-line and maintenance therapy for ovarian cancer. And reclassification, as I mentioned, of VUS variants is very important. Genetic counselors should not directly recommend no action on VUS variants, but should make an effort to, on case-to-case basis, by looking at other parameters such as family history, segregation analysis, and other affected individuals. Thank you.
An overview and comprehensive review of all these new testings in this field of genomics. So it's very exciting. So thank you for sharing that with us. So for our last speaker will talk on Olaparib patient experience in ovarian cancer. Let us welcome to the virtual floor Dr. Jericho Thaddeus P. Luna. Dr. Luna.
Thank you, Ren. Thank you, Rennie. Sorry. I'm not allowed to share. Rens, can you see my slides? No.
No, we can just see several screens. We'll
Okay.
just wait for them. We'll just wait for them. So far we have some questions already in the chat box. So please keep them coming, and we hope we can answer all your questions tonight. It's your opportunity to ask our expert speakers.
I don't know how to make the slide come out because the one that's seen here already. There, can you see it now?
Yes, we can see it.
Okay, yeah.
Okay.
Thanks, Ren. Okay, good evening, my dear colleagues, but I cannot see myself. I can only see the slides. So I don't know if my face is in proportion with the screen. This session is supported by AstraZeneca, and I'm just going to share an experience with one of my patients that Dr. Jean Tural is co-managing with me. For my disclosures, I'm a faculty for the following companies, and I deliver lectures and I receive honoraria for such lectures. So Olaparib patient experience in ovarian cancer. I have one patient so far, a year already into treatment. She's a 29-year-old female who came into the emergency room at Capital Medical Center because of a few hours onset of severe abdominal pain. And the ultrasound done by an expert gynecologist showed an ovarian new growth that was probably malignant. Past medical history is unremarkable. Significant family history is the mother is a survivor of ovarian cancer. Personal social history, single, no vices, menses coming in regularly. So our intra-op diagnosis then was ovarian cancer, stage 3A1 double I, because of a solitary palpable para-aortic lymph node measuring more than 10 millimeters. And that the ovarian mass was densely adherent to the rectosigmoid. So we did the usual debulking procedure and staging procedure from fluid cytology, removal of the uterus tubes, ovaries, infracolic omentectomy, peritoneal biopsies, lymph node dissection. And we, because of the adhesion of that ovarian mass into the rectal sigmoid and actually to the pelvic peritoneum, we also did pelvic peritonectomy, and I called on a friend surgeon to do the rectal shaving with adhesiolysis and enterolysis at that portion, and we were able to achieve zero residual tumor. Final diagnosis with the histology came out to be consistent with the intraoperative diagnosis, and the histology is high-grade serous carcinoma. So this was actually more than a year ago already, because she is on olaparib for the past year. So the initial adjuvant treatment we presented, or I presented, was paclitaxel carboplatin, and I offered her to receive bevacizumab together with the chemotherapy, followed by maintenance therapy. But the patient and family decided to just stick it out with paclitaxel and carboplatin. So 8 months post chemotherapy, there was an asymptomatic increase in CA125, and PET CT scan at the time showed metabolically active retroperitoneal lymphadenopathies. So my impression at this time, 8 months post paclitaxel carboplatin, was tumor recurrence, platinum partial sensitive. So I applied here and advised the patient on the Calypso trial on platinum partial sensitive, and offered the patient carboplatin with pegylated liposomal doxorubicin, which she completed 6 cycles, and the CA125 normalized at the end of the sixth cycle. Actually, after half of the intended number of cycles, the CA125 already decreased and became normal, further decreasing towards after the sixth cycle. And a repeat PET scan after the sixth cycle of pegylated liposomal doxorubicin with carboplatin showed already no evidence of disease, or no evidence of any hypermetabolic disease. Now, for disclosure purposes, I actually submitted and advised the patient to have the tumor, the ovarian cancer tumor, undergo BRCA mutation. At that time, AstraZeneca had a promotion on particular patients who might benefit with BRCA mutation determination. So we submitted the original tumor, and it came out to have a somatic BRCA mutation. So this is somatic because it was based on the tumor and not the germline. I thought of it being tested. The recommendations of our colleagues in the Western countries is BRCA mutation testing should actually be advised to all patients with high-grade ovarian cancer, whether serous or endometrioid. So, unfortunately, there was no, fortunately, at this time, there was compassionate use availability already for the use of olaparib, and following the SOLO-2 trial that Dr. Siasu presented, that the patient actually qualified under the patient population. So you would see here, I enlarged the font and made it bold. For Solo 2, platinum sensitive, high-grade serous ovarian or high-grade endometrioid cancer relapsing following more than or equal to 2 prior lines of platinum based chemotherapy. So she already received 2 here. I consulted Dr. Toral also, because the patient is also a good friend of Dr. Toral, and both of us agreed on the use of olaparib here as a second line, noting and following, since it's one of our first times to experience the use of olaparib, we had to look back into the solo trials and find out, because at this time the Paula trial was still not out. Study 19 was also out, but I used the randomized controlled trials. And you're going to see I highlighted the grade 3 or 4 events that can be felt with olaparib monotherapy. And you're going to see that in terms of percentage, grade 3, grade 4, practically none. Grade 3, anemia, then you might have a little neutropenia or myelosuppression, not that much of nausea, vomiting. So I opted not to maintain the patient on any antiemetic, and I just monitored her CBC. So this is the CBC. After a year of being on olaparib, the patient's uncle is a hematologist. So there are at times that the uncle himself was the one requesting the CBC. You would see that there are only 2 times that the hemoglobin went lower than 100. last May 21. So that's February, March, April, May, June, July. So around 4 months into Olaparib, the hemoglobin went down below 100. The hematologist just asked the patient to continue the iron intake and also gave erythrocyte stimulating agent once a week at 10,000 units to try to keep the hemoglobin up. Unfortunately, less than a month after, approximately a month after, the repeat CBC still showed the decline of 79.23. This is the approximate time that you will see in the next slide that the patient was also feeling some abdominal pain or gastritis, which was relieved when she stopped the iron intake. So we collaborated. I discussed this with the hematologist and the patient last June underwent blood transfusion of 2 units, after which she felt better already. Now, if you will notice, by July 21 onwards up to this month, the patient's hemoglobin actually improved and got stabilized at 110 and above. So she's already off erythrocyte stimulating agent, and she is maintaining herself on oral iron, which I will present on the next slide. You would see that there was no problem in white blood cell count in terms of absolute neutrophil count. Platelet count was okay. So this is consistent with the Solo 2 trial in terms of adverse events. When you look at the product leaflet of Olaparib, they are also mentioning that at times you need to monitor the renal function tests and sometimes the liver function test for hepatotoxicity to find out if you will adjust the dose. But so far, the creatinine was okay, at least in the 3 determinations in the past year. The patient did not have any liver function tests done. I'm not sure if she had it done this month. There is still no update in terms of the chemistry. So as mentioned, around the time that the hemoglobin went down, she had some feeling of weakness that was correlated with the anemia, feeling better after the transfusion. She did develop fever, and remember, because of this pandemic, of course, we did her test for RT-PCR swab test, and fortunately, it was negative. To my knowledge, she hasn't had any season 1 with COVID, and so far, the fever at the time was self-limited and was attributed to just another type of viral infection. The gastritis she felt was actually subsided when the oral iron stopped, and after reviewing the literature, including some of my presentations in iron supplementation, she shifted her oral iron intake to 1 tablet every other day, and it actually decreased the probability of, or not, the sensation of upper abdominal or epigastric discomfort. So how's the patient now in terms of CA125 and PET CT scan? Well, I've been advising her to have the CA125 done every 3 months, but you're going to see here more or less she followed in the first three. The 7.97 was the prior to the initiation of Olaparib. She started it at February 18, further going down in April, increased in August 25, and despite the advice of having the CA125 repeated, she only had it repeated February 24, this week, just this week. The PET CT scan is also due, actually overdue, but the patient did not have it done, but she will have it done after her creatinine results come out. And I'm hoping that the 1 year treatment of Olaparib is still continuously uh, controlling any disease recurrence for this particular patient. So a question that boggled my mind here is, of course, the application of Solo 1. Could I have actually tried to apply for compassionate use on Olaparib even after the carbopaclitaxel 6 cycles post-surgery, where she did not have any evidence of disease after first-line chemotherapy? Remember, in Solo 1 actually includes patient in clinical complete response or partial response after platinum-based chemotherapy. So looking back, but that was more than a year ago. I am not sure if compassionate use was already available at the time, but probably looking back into the practical application of our first lecturer's presentation, the patient would have been a candidate no, for olaparib maintenance treatment after the first cycle of paclitaxel carboplatin. I'm sorry, forgot to highlight the first bullet. So the first bullet, solo 1, includes FIGO stage 3 for high-grade serous or high-grade endometrioid ovary, primary peritoneal, or fallopian tube. Exactly what our patient had after her first operation. And looking at the side effect profile, I did not show anymore the graphs, the Kaplan-Meier graphs. Dr. Shaso already presented that. And you would notice that even if we give it after the first line chemo, not too much side effects in terms of adverse events grade 3 or 4. We really just need to monitor her CBC because of a 22% probability of anemia and a 9% probability of neutropenia. And that's with what I've been doing with this patient. And fortunately, her uncle is a hematologist. So he is also monitoring the myelosuppressive effects of olaparib together with me. So with that, I would like to thank AstraZeneca for giving me the opportunity to share this patient and for helping. I also would like to thank them for helping this patient get supplies of olaparib even before it became available through the market in the Philippines. So thank you again to AstraZeneca, and thank you, Rennie, for giving me the floor to present my patient experience.
Your patient, and we also thank the patient through you for making her be part of our, so that we learn, because we always learn from our patients. So okay, so let's call on everyone, Dr. Shasu and Dr. Agarwal, to the panel discussion and question and answer. Okay. So we can start with the first question. So we have one from the floor, and I think this should be addressed to Dr. Shasu, but people can, Dr. Luna can also answer. So Dr. Palma is asking, are there studies of olaparib on advanced mucinous and endometrioid or clear cell ovarian cancer?
Okay, olaparib in solo 1 was studied on advanced serous and endometrioid cancers. I think mucinous cancers were not generally included because mucinous types of carcinomas are less likely to be BRCA mutated. So maybe that's the reason why they did not include the mucinous subtypes. But if you do have a patient with mucinous carcinoma and BRCA 1 or 2 mutation, or HI or homologous recombination deficient patient, then maybe olaparib can be given to this patient in those scenarios that we have presented.
So theoretically, maybe it could be given, because if you look at the NCCN guidelines, it says there that all patients with epithelial ovarian cancer should be tested for mutations BRCA1 and also HRD. So it doesn't really specify that should it be endometrioid, but maybe that the studies that you have shown were mostly on high-grade serous carcinoma
Serous and endometrioid.
and
The solo one
endometrioid.
included endometrioid carcinomas.
Yes. Okay, let's go to the next question. So the next question is, when do we ask for BRCA versus HRD test? I will ask Dr. Agarwal. Dr. Agarwal, can you, because you had these algorithms, right? I saw your algorithms or flow charts on what to ask. So what to request for. So what do you ask? Do you go for BRCA versus HRD?
Yeah. So I would like to first of all put a scenario where the BRCA1 and BRCA2 genes, they are involved in homologous recombination pathway, as explained by Dr. Maria also. And when there is a loss of function of BRCA1 and BRCA2 genes, homologous recombination pathway is defected, and that leads to HRD. Eventually, it will lead to homologous recombination deficiency. So, if we are testing for BRCA1 and BRCA2, we are ultimately testing for HRD. And for this, olaparib is recommended as first line of maintenance along with bevacizumab. So, when an ovarian cancer patient presents in the clinic as a newly diagnosed or treated with, first lines of therapy, so first of all, BRCA1, BRCA2 should be tested. If BRCA1 on tumor tissue, if BRCA1, BRCA2 comes out to be negative, then to identify the BRCA wild type HRD positive cases, we should go for HRD testing. So as I said, if you remember my first slide, so BRCA1, BRCA2 mutated cases are 20% cases of high-grade ovarian cancer. Rest of the cases are not BRCA1, BRCA2 mutated, but they can be 30% of ovarian cancer cases, but they can be HRD positive. Why? Because there can be mutations in other HRR genes, or there can be other unidentified causes which leads to genomic instability and hence HRD. So all HRD positive cases are indicated for Olaparib treatment as FDA has approved. So I would recommend go for BRCA1, BRCA2 testing on tumor tissue first, followed by HRD if BRCA1, BRCA2 is negative.
Yes, okay. So
I hope.
you had that algorithm. So you're
Yeah.
recommending that if you have a patient newly diagnosed with ovarian cancer, the tumor, which is fresh frozen, no, formalin fixed, right? Formalin fixed tumor, that's less than 33 years, right? You said 3 years old, right?
Yes.
Not older than 3 years old. You test it first for somatic mutation, and then if it's negative, then you go for the HRD test. And then if it's positive, if it is
Yeah. If it
positive,
is
then
positive.
you go on for germline, because you also
Exactly.
want to see if the family tree is also affected. So I think that helps
Exactly.
us as clinicians to sort of see where we will go and what test to test
Yes.
first. Okay. So I
Thank you.
think there is a question here. So since we're already talking about HRD, let's talk about is there commercially available HRD?
Yes, there are commercially available HRD tests.
Mm-hmm.
So currently in India, MedGenome is offering HRD track test, and
Mm-hmm.
Myriad is also offering HRD test. So there are commercially, and there are other companies also who offer HRD testing commercially.
Okay. All right. Can I ask Dr. Luna? Dr. Luna, for your patient,
Yes.
not listening, for your patient,
Yeah.
what did you do? Like when you said you tested her, how did you test her? How did you?
Actually, it was easy for me, Rennie, to convince
Mm-hmm.
her or to advise her because she's a doctor.
Mm-hmm.
So even before I advised, and that made it easier to explain the need for BRCA testing, especially because she and her mom had ovarian cancer also. So they were really looking into the probability of a BRCA mutation because she has one more sister who hasn't had ovarian or breast cancer. So they were kind of worried, and it's fortunate that at the time that she was undergoing second line treatment, the offer of AstraZeneca for free BRCA testing at high precision came in. So definitely less than 3 years from her surgery, we were able to process it, and very much interested. Their only thought bubble at that time, even when I said my thought bubble was, should I have given Olaparib in her first line, because at that time Olaparib was not yet available. So aside from the cost, the difficulty of trying to have it brought here, no, processed, it was just very fortunate that towards the second line treatment, AstraZeneca was already very active in promoting BRCA testing and was more than willing. They have a division in their company who is able to help patients try to purchase, no, the Olaparib. So not that much difficult for me. And because she tested positive and the mom had ovarian cancer before, the sister underwent eventually germline testing, and she's
Mm-mm.
also positive.
Oh, so it means that in terms of the patient, there's no hesitancy. So on the
No.
patient side, it's easily acceptable. So I mean that's the first hurdle for the person to agree to have herself
Yes.
tested and the relatives. And then the second is the ease of having it tested because the AstraZeneca was there to help you.
Yes.
And I do recall they were giving
Yeah.
handouts, yeah, to apply if you wanted your patient to be tested.
But I
Okay.
also advise them that in case there's a mutation that happened, I need to ask them to consult a genetic counselor,
Yes, yes, yes.
especially now because the sister is also positive.
Yes. Okay. That's also important. Maybe another webinar on genetic counseling.
Yes.
Okay. I think there's a note here in the chat. I'm being prompted to say that we only have BRC germline and BRC tumor at the moment, and they will finalize the HRD testing also. I think this is from AstraZeneca. Okay, so let's go to the next question. So this is practical again, and this is for Dr. Luna. What is the dosing and any practical tips on olaparib management?
Oh,
So
it's 300 milligrams, as what Dr. Shasu mentioned, twice a day. Their preparation is 150 milligrams per tablet. So the patient just has to take 2 tablets per day. So that's like 4 tablets in a day.
yes, 4 tablets
So,
in a day.
so times 30, 120 tablets. That's why it's quite expensive. I'm just happy that it's something like she developed already she already achieved a symbiotic relationship with the intake of olaparib after about 6 months. And so far, she's doing well. I'm just praying that the CA125 is still less than 10, and that the
Mhm.
PET CT scan a year after olaparib is still negative. I'm
Okay, when
also
you
nervous.
okay, so when you say symbiotic relationship, there was some coping. She had to cope with it. Like she felt
Yeah,
some adverse
the
reactions.
first the first reaction she felt was the gastritis. She thought it was because of the intake of olaparib, because there's report of abdominal pain. But when because being a doctor, she stopped the iron intake, because oral iron can also
Mhm.
cause gastritis. And when she stopped the iron, the gastritis resolved. And then with her uncle as a hematologist, told her that it might be better to take her 1 tablet every other day, which is actually a published study also. And I included it in my oral iron lecture. Other than that, she was, except for the blood transfusion, there was one time that she had to undergo blood transfusion. After that, okay na siya for the past, since July. She's been okay. No blood transfusion and no erythrocyte stimulating agent injections.
Okay. Dr. Shasu, since you reported on all the studies, can you say the
Wait,
number
Randy,
one?
I'd like to
Yeah,
add
yeah.
something to what
Oh,
Ricky
yeah, yeah.
said.
Yes.
Yes, yeah.
The dosing is really 300 milligram tablet, so 150 milligram tablet taken twice daily. But should you have a dose reduction because of some adverse events, like you have anemia, which is recently corrected, or recurrent, or other symptoms that you have to reduce the dose, you have a 100 milligram tablet also
Tablet. Correct.
available. So you can reduce until 200 milligrams twice daily. Otherwise, you have to stop your treatment and rethink about giving the PARP inhibitor.
Okay. So, ma'am, of course, we think of the extreme. Now, when you look at when you look at all the adverse reactions, it's more like nausea, right? Feeling nauseous, maybe a little bit feeling weak. What is the alarm symptom? What is the most alarming adverse reaction that we have to watch out for?
I think what was reported was super low hemoglobin levels, or when the patients would have very high WBC counts, no? Because the reported grade 4 adverse events was on leukemias, secondary malignancies occurring in patients on prolonged treatment, chemotherapy, and all the other treatments. Remember, these patients are patients who have received previous adjuvant therapies already, second, third, fourth line of treatment before receiving olaparib as well. But um, the grade 3 and grade 4 were mostly on anemia, and grade 4 was really leukemia and
All right.
myelodysplastic MDS.
Okay. So that's why Dr. Luna's patients had several CBC
Yeah.
You
extraction
really have to test that every month.
every month. Okay.
Every
So
month.
that's a practical point. So when we prescribe it, then we have to look at the CBC every month, and we have to look for myelodysplasia. I mean, that's the most extreme. But
Yeah.
then just mild
Or
anemia
leukemia.
or leukemia. Okay.
Leukemia reactions already.
Okay. All right. But that's rare. It's rare,
That's
right?
rare.
It's
It's
very
rare.
rare.
There.
Yes.
Okay. All right. So, is there? We can fashion it. We go to the next question. I there. Okay. Since olaparib indication is quite in first line is quite broad. Okay. So, how will you choose patients for combination olaparib plus bevacizumab?
Maybe
So
you
here,
look at it's in
go
the
ahead.
Paula 1 study. The Paula 1 study showed patients were given their chemotherapy plus bevacizumab as standard adjuvant therapy. And one arm of that, they receive olaparib, okay, during the time of treatment. So that's 6 months. Thereafter, an arm was on bevacizumab for 15 months. Di ba? Yun ang maintenance ng bevacizumab. Okay? Another arm had bevacizumab with olaparib. So they would say that in the Paula 1 report, it showed a better PFS, no? With the combination beva and olaparib. So the combination of the anti-angiogenesis as well as the PARP inhibitor probably might had improvements in the PFS of these patients.
Okay. I think this maybe the context of this question is asking, in which patient would you choose? If you who is the ideal patient in which you would give um, olaparib as first line with
For the BRCA
bevacizumab?
mutated tumors, BRCA mutated, they should have BRCA mutation. If your patient does not have BRCA mutation, then you continue with your bevacizumab maintenance therapy.
Okay.
And
So
beva is given for 15 months.
okay. Dr. Luna, would you like to answer this question also? Your opinion?
No, no, exactly what Dr. Shasu mentioned. Your determining factor here is the BRCA mutation. So BRCA mutated and the patient can afford olaparib plus bevacizumab. No, if non-BRCA mutated or no HRD, recombinant deficient state, then beva definitely. If patient also can afford.
Okay. All right. Okay, let's is there another question? Okay. So before we go to the price, I think that is the end. That is the end point of the. It's what everyone is curious about. Let's leave that to the end. Let's talk to Dr. Agarwal. So I was just thinking because you said so we're showing that we have to test BRCA. We have to make sure that we actually we catch it accurately. So how would you advise us clinicians, because we're actually surgeons, gyne-oncologists, for surgeons, how would you advise us on how to process the specimen? I know you had some discussions on that, but maybe just give us some reminders on how we process our specimens so that when we hand them over to the lab, it will be okay.
So the point I highlighted for tissue specimen from the surgeon side is that the time lag between tissue processing and tissue dissection, that should be reduced. As and when tissue is dissected, it should be embedded into FFP paraffin block. Processing should be started, fixed, and it should be started. Plus, from not from the surgeon side as per se, mainly from the histopathological side, it is important that fixation time and the percentage of formalin that is used to fix the tissue, that should be optimized. So those are the major issues. And then the quality of the paraffin is also important. Sometimes the paraffin is not so pure, the contaminants are there. So that also affects the quality of the FFP block. So more on the histopathological side as per se,
So
it affects the quality.
it's out of the surgeon's hands, but sometimes we take responsibility when our specimens are not processed That's what we learned
Yeah.
in our
So,
rotations.
yeah, maybe from surgeon side, when we are dissecting the tissue, I don't know. I am not a surgeon, so I don't know how it will be. But when we are taking out the tissue, we should avoid necrotic site and the sites which has like pus or mucus. Those type of sites we should avoid, because if mucinous cells are there or the cells are not intact, then the DNA quality will not be good.
Okay. All right. So thank you for your answer. Okay, we have one more question, and then we end with the price question. So Dr. Zalameda Castro is asking, in that study, so I think she's talking about Paulo one.
Paano
When was olaparib started? After the chemo?
No. In the Paulo 1 study, this was a combination of carbopacli plus bevacizumab plus olaparib during the first 6 months. Beva is given at the second cycle, right? So olaparib is given day 1 to 10 during these 6 months. Thereafter, it's given continuously. But in the other studies, as monotherapy, maintenance monotherapy, it is given soon after, 3 to 8 weeks after the chemotherapy. Remember, these patients that were studied should be platinum sensitive, achieving complete response or partial response. Okay, so soon after, if you want to give it as maintenance monotherapy, then you can give it within 3 to 8 weeks after your chemotherapy. And then it's given for a period of 2 years. At least
Okay.
it's
All
a
right.
daily dose. It's a daily dose.
Okay. Okay. So to follow up also, there's a question addressed to Suriki from Dr. Palma. Suriki, did you mean chemo plus beva and olaparib all at the same time? I think that's what
I
Dr.
think
Shasu
that's what
was
Dr. Shasu just
explaining.
mentioned. Yeah.
Mm-mm. Yeah, that's what she explained. Okay, so there. So in a way, it is in at the same time. Okay. All right. Okay, so now more questions on the cost. So let's go to the question of the night. How much is the local cost of olaparib? Let us hear from Cheska Laconico. Cheska of AstraZeneca.
Hello, good evening, everyone, and thank you for attending the session. So, in relation to the cost, Olaparib will be launched in April. So, by the time Olaparib is launched in April po, the price range we will communicate as well. So, it's more than around 60% discount range. So, it's going to be very different from the current EAP price po. So I won't communicate pa the exact price, but our easy reps will be in touch with all of you. So we have dedicated gyne-oncology reps as well. So I hope you will be able to engage with them more in future events so that they could communicate the price of olaparib, as well as the BRCA testing programs of AstraZeneca. So we have here Dr. Agarwal. Thank you very much from MedGenome. So we do have a partnership with MedGenome via High Precision. So there are discounted BRCA testing programs with AstraZeneca. So thank you very much.
Okay.
Thanks.
Okay, so we'll still wait for the final answer on that, but of course their channels are always open to us, so we can just communicate with them after this webinar. Okay, so it's already we're going to end already. So I'd like to thank all our speakers tonight, Dr. Shasu, Dr. Agarwal, Dr. Luna, for sharing your knowledge and your experience to our audience at this night. So for the closing remarks, let me call on Lotis Ramin, the country president of AstraZeneca Philippines. Lotis.
Sikam. Hi, good evening, everyone, and thank you, Dr. Sikam. And first of all, thanks to our distinguished panel of speakers and moderator, of course, Dr. Siesu, Dr. Luna, Dr. Agarwal, and of course, our moderator, Dr. Sikam. And also thanks to the UP-PGH Division of Gynecologic Oncology and the Department of Obstetrics and Gynecology for providing us this platform. Now, next slide, please. Our vision, in line with our values of putting patients first and following the science in AstraZeneca, is to eliminate cancer as a cause of death. And with this, our approach is focused around targeting the underlying biological drivers of cancer by focusing our research on different scientific platforms, including immuno-oncology, tumor drivers and resistance, antibody drug conjugates, and DNA damage response. We also concentrate on biomarker driven indications, utilizing precision medicine to dramatically improve 5-year survival in 5 tumor types, including ovarian cancer and non small cell lung cancer. Being patient centric, we help identify and hopefully treat patients earlier in the course of their disease with our curative intent, and also support relapse and refractory patients by tackling primary or acquired resistance. Finally, we leverage on our global presence to ensure that we bring our innovation early to patients who need them. Next slide, please. Now, truly, today is a very important event. And as we know previously, the treatment of advanced ovarian cancer was a story of marginal increases in progression free survival that perhaps left you, physicians, a little uninspired about the promise of PARP inhibitors. But then entered Solo 1, which is the revolutionary phase 3 trial, whose results actually evoked audible gasps when they were first presented, and we're truly proud of this. With the unprecedented efficacy that was seen in Solo 1, where Olaparib, with 2-year maintenance, provides more than 4.5 years of progression free survival, with around 50% of patients with progression free after 5 years. Therefore, Olaparib has the potential to redefine the goals of first line treatment and for the first time help us reimagine and treat with curative intent. Next slide, please. And as has been presented this evening, Lynparza or Olaparib offers the broadest clinical utility of any PARP inhibitor with 7 indications across 4 tumor types. We therefore encourage you to consider BRCA and HRD testing early at diagnosis to aid informed treatment decisions. And we're always very proud of our oncology portfolio and pipeline. And we hope that together we can realize our vision of eliminating cancer as the cause of death and help cancer patients enjoy more precious moments with their loved ones. Thank you very much and have a good evening.
Thank you, Ma'am Lotus Ramen, Dr. Maria Elizabeth Shasu, and our moderator, Dr. Rene Dinasikam. We would like to hear from you to see how we could further improve our future activities. We will type in the Zoom chat form the code for the quick survey via forms. This has been Dare to Dream, reimagining management of advanced ovarian cancer across lines of therapy with first-in-class PARP inhibitor Olaparib, Lynparza. Good evening, everyone.